بسم الله الرحمن الرحيم. أنا اسمي الدكتور محمد خطاب، أستاذ الأمراض الباطنة والسكر بجامعة القاهرة ورئيس الجمعية المصرية للسكر ودهنيات الدم. On behalf of the board of the Egyptian Society of Diabetes and Lipidology, it's my honor and pleasure to open the second wave of the Diabetes Guidelines Implementation Summit, which is a meeting that is joint work between the Egyptian Society of Diabetes and Lipidology and the cardiovascular working group of the European Association of the Study of Diabetes. In this two nights meeting, we have three eminent foreign guest speakers representing the ASCD and two eminent Egyptian speakers. Let me welcome them all, and let me welcome specifically Professor Antonio Ceriello, the president of the Cardiovascular Working Group of the European Association for the Study of Diabetes, Professor Andre Sheen, and Professor Doina Catrioni. I welcome also the Egyptian speakers and the board of the Egyptian Society of Diabetes and Lipidology. And it's my honor to present Professor Ceriello to give a welcome note to the audience. Professor Ceriello.
Thank you very much, and welcome everybody to this second waves of this webinar, which is a proof of a very strong cooperation between the ESD study group on cardiovascular disease and the Egyptian Society of Diabetes and Lipidology. So are some years that we are working together. As you see from the program, as a study group, we decide to touch a very important topic today, which is the management of the problem of the COVID and cardiovascular disease in diabetes. We will see during the meeting how this is very relevant and important for people with diabetes. So thank you again for joining this webinar.
Thank you, Professor Ceriello. And now it's my pleasure to thank first and introduce second Professor Salah Shilbaya, who is the organizer of that meeting. Professor Salah.
Thank you, Dr. Khattab. Thank you, Professor Ceriello. I'm very happy to introduce the second wave. I think that the first wave was very successful, and I have a very good feedback from the attendees from the first wave. I hope the second wave will be also, and I think it will be very successful tonight. In order not to lose time, I'm transferring again to Professor Muhammad Khattab, the president of our society, to start the first session. Professor Khattab.
Thank you, Professor Salah. The first presentation in this tonight's meeting is titled Prevalence of Diabetes in COVID-19 Patients. It will be given by Professor Andre Sheen. Professor Andre Sheen is the head of the Division of Diabetes, Nutrition and Metabolic Disorders at the Academic Hospital of Liege, Belgium. He is also a professor of medicine and therapeutics at the Faculty of Medicine of the University of Liege, where his main academic interests include the pathophysiology and treatment of obesity and type 2 diabetes mellitus. You are welcome, Professor Andre Sheen, to give the presentation in a virtual way to the Egyptian attendees. Professor Andre Sheen.
Good evening, everybody. First of all, I would like to thank the Egyptian Society for the invitation and also my friend Antonio Ceriello. So my task is to discuss with you the prevalence of diabetes in the COVID-19 patients. I have no conflict of interest related to this lecture, but I have a lot of interest with the pharmaceutical companies involved in type 2 diabetes mainly. So when we have to discuss about the interaction of these two pandemics, COVID-19 and diabetes, I think that we are facing two heterogeneous chronic disease. Diabetes mellitus, as you know, it is an heterogeneous chronic disease. We have to separate clearly type 1 diabetes from type 2 diabetes. But even among patients with type 2 diabetes, some patients are young, others are old, mainly the majority are old, in fact. Most patients are obese, but some patients are non-obese, and patients are also with and without complications, mainly cardiovascular complications. So a very heterogeneous chronic disease. When we consider COVID-19, it is also a heterogeneous disease, an acute infection, but most of the patients are asymptomatic, but some patients are symptomatic, as you know. Most patients are not hospitalized, are seen ambulatory, but some patients should be hospitalized with severe or non-severe illness. Some patients have to be admitted to intensive care units, others none. Some patients should receive only oxygenation, but also some artificial ventilation. And we have also to discuss about the prevalence of in-hospital mortality. So in fact, these two diseases are very heterogeneous, and so it's not a simple question to discuss about the prevalence of diabetes among patients with COVID-19. There are in fact some similarities between the two diseases, despite the fact that type 2 diabetes is a chronic disease and COVID-19 is an acute disease. Type 2 diabetes, chronic disease, of course, the prevalence is increasing with aging. Most patients are asymptomatic, and obesity is a recognized risk factor. Hypertension is also frequently associated to type 2 diabetes. It is also a risk factor. Most patients, not most patients, but a lot of patients have cardiovascular disease. And type 2 diabetes is characterized by also a low-grade inflammation. And this disease is associated with an increased mortality. When we try to compare with the COVID-19, of course, it is an acute disease, but there are some similarities because the prevalence of severe disease is increasing with aging. Most patients, like type 2, are asymptomatic, and also obesity is a risk factor for severity as well as hypertension. Cardiovascular disease is also a complication of the disease, besides the classical pulmonary disease. And as you know, COVID-19 is characterized by acute inflammation. We are speaking about a cytokine storm. And of course, the disease is associated with increased mortality. So despite the fact we are comparing a chronic disease and an acute disease, which are completely different diseases, nevertheless, there are some similarities between these two diseases. So I will cover briefly these 5 topics, and we will start with the prevalence of COVID-19 in patients with type 2 diabetes. When we look at the literature, you can see that we have several data, and here it is a meta-analysis of more than 1,700 patients. Young patients, because the average age is 41 years, as you can see in the bottom of the slide. And you can see that among the comorbidities associated with these patients with COVID-19, 9.4% have type 2 diabetes. So quite high prevalence. But in fact, when you look at the literature, here it is a meta-analysis, let's say a systematic review, which was published a few weeks ago. And you can see that the prevalence in China, in Italy, and in USA is very different from studies to studies. In fact, it seems that the prevalence of type 2 diabetes is lower in China, between 10 and, let's say, 19%. And in Italy, it was around 30-35%, quite higher. In the States, it depends on the statistics. Some studies show a very high prevalence, around 50%, and other studies showed a lower prevalence, around 11%. Here is another paper published recently in Lancet Diabetes Endocrinology by an Italian team. And you can see again, it is a systematic review with retrospective studies, meta-analysis. You can see also that there is a big heterogeneity between, when we consider the prevalence of diabetes among patients with COVID-19 between, let's say, 10 and 45 or 5 to 45%. But anyway, when we consider the risk of severe disease and mortality, the risk is multiplied by 2 to 3 in patients with type 2 diabetes compared to patients to non-diabetic patients. Here it is another meta-analysis published by a Chinese group, retrospective studies from China, and you can see that the prevalence of type 2 diabetes is around 9%, with a confidence interval between 6 and 12. But it is very difficult to have the real prevalence of COVID-19 in patients with type 2 diabetes who are not hospitalized, because we have very few data. And in fact, most of the data which have been published are in patients who were hospitalized for the COVID-19, and mainly hospitalized with severe COVID-19. Here is the first study, again, this meta-analysis from China. You can see in patients hospitalized with moderate disease that the prevalence is quite low, let's say 7%, which is not very high. But when you consider patients with severe illness, you can see that in China, from 7, the prevalence is increasing to 17, so it is multiplied by 2.5 when you consider severe patients compared to moderate patients with COVID-19. And here it is this comparison between severe versus moderate. You can see the odds ratio, and on average, the odds ratio is 2.5. It means that the prevalence of patients with severe illness is 2.5 higher, patients with type 2 diabetes, 2.5 higher with severe illness compared to moderate illness. And this is confirmed in another paper published by a group from India. You can see in black the patient, non-severe patient. All patients have the diabetes. Black column is non-severe compared to gray column severe. And you can see that the gray column is almost higher, is twice higher, 2 to 3 times higher compared to the black column, confirming that severe illness is more prevalent in patients with type 2 diabetes. Of course, when we consider patients with diabetes, we have also to discuss about the age. And here it is a paper who considers the different prevalence of the comorbidities, hypertension, obesity, and diabetes, considering according to the age group. 3 age groups are considered between 18 and 49, 50, 60, 64, and above 65. And you can see even in the young patient, the prevalence of diabetes is quite high, around 20%. Of course, it is increasing when age is increasing. One crucial point is, of course, the mortality, which is a very crude outcome. And we are aware that there is an increased mortality due to COVID-19 in patients with type 2 diabetes. Here it is a statistics from New York, and you can see that the leading comorbidities among patients, 19 deaths in New York. You can see that besides hypertension, diabetes is very prevalent, with a prevalence of 37.5%, which is much more than the other comorbidities, including chronic pulmonary disease. So diabetes is very prevalent in patients who died from COVID-19. And it is also recognized in this analysis published by the group from India, when they compare survivor in black and non-survivor in gray column. You can see that the non-survivors of the patient who died the prevalence is almost twice as high as compared to the survivor. You can see that it is very consistent across the study. And just to summarize what I have explained until now, here it is a recent paper only published online now, considering the prevalence of diabetes, which is the topic I have to cover. On average, you can see that the prevalence is around 12%, which is almost the same as we have discussed before. When you separate, and this work was able to separate outpatient and inpatient, so outpatient, patient, ambulatory, you can see that the prevalence is very low, 3%. So almost the same as in the general population without COVID-19, 3%, which is very low. But when you consider the inpatient, it is increasing up to 12%, and with severe COVID-19, 18%, and non-survivor, 30%. So you can see that the prevalence of diabetes is depending about on the severity of the COVID-19. Ambulatory patient, low prevalence, inpatient, higher prevalence, patient with severe disease, higher prevalence, and patient who died from the COVID-19, the prevalence of diabetes is very high, around 13%. And you can see again that when you consider the diabetes as risk factors, you can see that there is an increased risk of severe COVID-19, admission in intensive care unit, and mortality. It is increased in patients with diabetes compared to patients with non-diabetes. So why is it is the case? Why is this increased risk of severe disease or mortality among patients with COVID-19 and type 2 diabetes? I had the opportunity to publish a paper a few weeks ago. It was a paper related to the Coronado study, which is a large epidemiological study performed in France, on more than 1,500 patients hospitalized with type 2 diabetes and COVID-19. And I analyzed at that time the data from this Coronado study and other recent papers. And in fact, when we try to consider what is the relation between diabetes, COVID-19, moving from severe disease and death, we have several topics to consider. Of course, the comorbidities associated with type 2 diabetes. One major comorbidity is obesity. We know that obesity is a major risk factor for dying from COVID-19. And also patients with type 2 diabetes and obesity have also frequently hypertension. They can have also sleep apnea syndrome, and sometimes also fatty liver disease, which also considered as risk factors. We have also some diabetic complication. We know that patients with previous cardiovascular disease or also renal disease have a high risk to die from the COVID-19. We have also a lot of discussion about the medication, and you can see here there is always a question mark. We don't know exactly if these drugs are able to modify the prognosis of this patient with type 2 diabetes. I will not cover the glucose control, but because I am sure that Antonio Cerello will cover this topic. But glucose control is also a major role in the prognosis of this patient. And we have to discuss about the glucose control before admission. What is the hemoglobin A1C of this patient, the glucose level at admission, and also what is the glucose control during the hospitalization. All these factors could influence the prognosis of the disease. And finally, I will end with a few words about the type 1 diabetes, because we heard that diabetes is a risk factor for COVID-19 and mortality and so on. But in fact, at least in Belgium and maybe also in France, the journalists did not separate patients with type 2 and patients with type 1 diabetes. And in fact, there are a few data in patients with type 1 diabetes. But I have found 2 papers here published in Diabetes Care and also in Diabetes Research and Clinical Practice. And in fact, when these 2 studies try to see if there is an increased prevalence of type 1 diabetes among patients with COVID-19, and here it is the results of a Belgian study. In fact, this group is from Belgium, and they conclude that there is no evidence for increased hospitalization for COVID-19 in patients with type 1 diabetes. And this was also found by an Italian group. And in fact, in this Italian group, there was a lower prevalence of type 1 diabetes hospitalized with COVID-19. And there were some speculation, as shown on this slide. There is some speculation that maybe type 1 diabetes could protect against severe COVID-19 because it is an autoimmune disease. We know that COVID-19 is associated with this immune response, and there are some speculation, but I think that it is only speculation. We cannot really conclude, but it seems at least that type 1 diabetes is not a major risk factor for severe COVID-19 disease. So if I may conclude on some key home messages. First, the prevalence of type 1, as just mentioned, is not increased and rather possibly decreased among patients with COVID-19. The prevalence of type 2 diabetes in asymptomatic COVID-19 patients is largely unknown because we have very few data, and probably it is not very different from the prevalence of type 2 diabetes in the general population, but we don't know exactly. But we know that the prevalence of type 2 diabetes in symptomatic COVID-19 patients hospitalized is higher compared to non-diabetic patients. And it is also higher in severe disease compared to the moderate disease. It is the prevalence is multiplied by 2 to 3. The prevalence of type 2 diabetes in non-survivors, so the patient who died, is much higher than in survivor, again multiplied by 2 to 3. There are several prognostic factors that have been identified to explain the higher severity. Old age is a very important factor. Obesity, hypertension, previous cardiovascular disease, high blood glucose, as it will be discussed later on. So I think that just to conclude, because this high prevalence of diabetes among patients with COVID-19 and also among patients with severe disease and disease who lead to premature death, I think that several actions should be implemented to improve the prognosis of the patient with diabetes hospitalized for COVID-19. And I think that the main 2 topics which will be covered by the next 2 speakers is first to target a good glucose control to improve the prognosis, and this will be covered, I'm sure, by Antonio Ceriello. And I think also the appropriate management in intensive care units is very important also, and our colleagues Donia Catrinolu will also cover this topic. So I think that I have showed you briefly the prevalence of type 2 diabetes among patients with COVID-19 in the literature. So I thank you for your attention.
Thank you, Professor Andrei Chin. And I will take this opportunity to ask you a question. The other face of the coin. Is there any signal or an evidence that COVID-19 infection may increase the incidence of diabetes in COVID-19 infected subjects who are not diabetics? Is there a signal of insulinitis or pancreatitis, taking into consideration that this disease is a multi-inflammatory systemic disease?
Yes, it is a good question. I think I did not cover this topic, but as you know, probably there is indeed some evidence that there is an increased risk of diabetes in patients with COVID-19. There is two possible explanations. The first explanation is only due to the infection, severe infection, fever, and so on. Sometimes some treatment. Some patients are treated with corticoids. So, of course, this will increase glycemia and induce some diabetes or worsen diabetes in patients with previous diabetes. It is one explanation, simple explanation. But there is also some evidence that this SARS-CoV-2 virus is able to provoke, as you mentioned, an insulitis and to trigger like a type 1 diabetes with sometimes ketoacidosis. Some ketoacidosis cases has been reported in patients with COVID-19. And I think it is not astonishing because we know that several viruses are able to induce insulitis, and probably COVID-19 is able also to provoke some insulitis. So it means that if you have a patient who develop an abrupt diabetes, severe hyperglycemia, you may suspect that maybe this patient develop insulitis and will require immediately insulin.
Thank you, Professor André Chin. And now the microphone is with Professor Hisham El Gayyar to present the second speaker. Thank you, Professor André Chin.
Thank you very much.
Dear colleagues, ladies and gentlemen, I welcome you to the first day of the second wave of Diabetes Guidelines Implementation Summit, which is a cooperation between the Egyptian Society of Diabetes and Lipidology with the EASD Study Group of Diabetes and Cardiovascular Disease. And I'm pleased actually to welcome Professor Antonio Ciriello, the president of the EASD Study Group of Diabetes and Cardiovascular Disease. He will discuss briefly with us some issues of diabetes management in the COVID-19 era. So you are welcome to start.
Thank you for the kind introduction. As already underlined by Professor Shin, diabetes, these are my conflict of interest. Diabetes is paying a very high price in the COVID era. This is just a meta-analysis showing how many people with diabetes are hospitalized for COVID-19. So for sure, this is an important comorbidity. And as you see from this report from the WHO Europe, which has been accessed to some months ago, but the situation is no different right now, you see that if you look at the concomitant comorbidity, comorbidities present in people particularly dying for COVID-19, cardiovascular disease, diabetes, renal disease, and obesity are the most important comorbidities. Of course, when we speak about diabetes, we have also to understand that all these comorbidities are all very often all together in a person with diabetes. So it's a very, very bad situation in a person with diabetes when she is affected by COVID-19. As Professor Shin already introduced, one of the most important aspects which really went out in the last months is that glycemic control is very important for the prognosis of this disease. This is a study which was probably the first published on this topic, and for the first time was found out that the people with a very good control of glycemia had a better prognosis in terms of complications, particularly about the possibility to die for COVID-19. And this cartoon is, in my opinion, is a very good example of what happens when somebody with high glycemia, with persistent high glycemia, is affected by COVID-19. you see that the survival rate when there is a very high high glucose, the survival rate is only around 11%. While people with good control, they have a very high chance to survive, about 99%. So 99%. So there is a huge difference between people who are well controlled or poorly controlled for glycemia in terms of what can be the chance to survive or to die. But what is also important is to see that hyperglycemia is a risk factor for worse prognosis, not only in people with diabetes, but also in people without diabetes. You see here, and this has been confirmed in many other more recent studies, that in people without diabetes, having high level of glucose is worsening the prognosis. But of course, is hyperglycemia just a marker, or is a causal risk factor for the prognosis? This is a study coming from Italy showing that when the glycemia was well controlled, the survival rate was dramatically increased. So you see, this is a small number of people, but has been recently confirmed in other studies. And it clearly shows that when glycemia is well controlled during the hospitalization for COVID-19, there is a better chance to survive for the people. And this I have to underline, honestly, that this was a topic of an editorial I published at the beginning of this story of COVID-19, when the first evidence was coming out suggesting that a good control of hyperglycemia could be really considered mandatory in order to improve the prognosis of the disease. I have to say the evidence, let's say, confirmed my opinion at that time. But I think that it's important also to understand how hyperglycemia is so bad in the case of COVID-19. Something that is less recognized is that the link of the virus to its cell receptor, meaning ACE2, is related to also the glycosylation of this receptor. In other words, the ACE2 receptor, to be a good carrier for the virus, must be glycosylated. And we know that glycosylation is, of course, one of the phenomena linked to hyperglycemia, particularly the label glycosylation is related to any acute increase of glycemia. Another consideration is that in the case of COVID-19, after many weeks, unfortunately, it was evident that probably the most important cause for the bad prognosis was the thrombosis. Meaning that when we were thinking that this was a respiratory disease, in fact, and this was due to some autopsies, the evidence was that the major problem was the increase of thrombotic risk. So this changed the approach to the disease, as also very recently has been underlined. And this has been confirmed. For example, in this study, you see that in people with diabetes and also in non-diabetes, there was an increase of D-dimer, which is a very good marker of thrombosis activation. And you see that particularly in diabetes, D-dimer was increased. And in the paper published in Diabetes Care from the Italian group, also a direct correlation between admission hyperglycemia and the level of D-dimer was found, suggesting that also hyperglycemia can condition this thrombotic predisposition during COVID-19. And this was confirmed because in the same study, when glycemia was well controlled, the D-dimer levels were going down, meaning that there was a conditioning of hyperglycemia of the level of D-dimer. I have to say this is not so surprising. And this is what I just described allow to put forward a possible hypothesis of this, how the SARS-CoV-2 infection can, through hyperglycemia condition, the worsening of the disease, but also the worsening of the prognosis. Because what is clear today is this virus can damage beta cells, and also in this way can induce a decrease in insulin secretion. On the other hand, it's well known that the cytokine storm produced by the infection also can induce or can worsen the insulin resistance. These two conditions altogether can produce hyperglycemia or can worsen hyperglycemia in diabetes. And the hypothesis is that through the glycosylation of the ACE2 receptor, there is a vicious circle which can worsen the disease. On the other hand, it's already known from many evidence that hyperglycemia through endothelial dysfunction, platelet activation, and the glycosylation of antithrombin 3 can favor thrombosis, leading to the multi-organ damage. So probably this can explain why if you tackle hyperglycemia, you can improve the prognosis, and also you can improve somehow the seriousness of the infection. And I have to say, and this is, let me comment a little bit, not only this slide, but what is behind. With the study group, we had the possibility to have a look at the published guidelines about the management of COVID-19. And when we were examining 31 different guidelines released by different bodies, including the European Heart Association, the American Heart Association, and many societies of ICU people, diabetes not mentioned at all. And this is really amazing. And this is why, as the study group, we decide to propose this kind of flowchart, trying to give some advices how to manage people with diabetes and COVID-19. I will not go in details. You see that there are two options. If somebody is entering the hospital, if it is just admitting to the hospital or you need the ICU admission, there is a different approach and the treatment. And I apologize because this has been published in March. And you see that in the suggestion is one of the suggestions is to abstain from steroids, which is not correct. I have to admit, today we have evidence that on the contrary, steroids, particularly in a very serious condition, they are very helpful. But I have to say that we adapted this suggestion from guidelines coming from the body of interventionists. So meaning that we trusted people managing people with managing a person with the COVID-19 in ICU. And if you see the first guideline published, it was clearly stated do not use steroids in this case. So sorry, but was not completely our mistake. So, but what about the diabetes management? What should be considered? I think that on the one side, we have to remember that some anti-hyperglycemic drugs probably can be helpful, particularly the GLP-1 receptor agonists and SGLT2 inhibitors can be very helpful. Of course, considering the possible side effects, we do not say to use, but also on the other hand, it's not correct to stop them. On the contrary, because one cardiovascular complication is present very often during COVID-19, we have to keep them as they are not showing really side effect. Particularly not only because they have beneficial effect on cardiovascular disease, but probably also because they have a very strong anti-inflammatory action. So probably this could be also helpful for this reason. On the other hand, again, you see here, these are the why the GLP-1 and the SGLT2 can be helpful in terms of preserving the reducing the inflammation. These are the mechanisms described here. One other point is that very often, at least until now, hydroxychloroquine has been used as a prevention, even as prevention. And we have to take in account that hydroxychloroquine, I don't know if it's helpful or not. I do not want to enter in this debate, that there was a paper showing that it's not effective was withdrawn from Lancet. Now we have some evidence against, some preliminary data with in favor. I have to say there is no one ongoing trial looking at the effect of hydroxychloroquine specifically in diabetes. But what is known is that several years ago, we were able to show that hydroxychloroquine could be useful in diabetes, but we have to use it very carefully because it can induce hypoglycemia. So this means that if hydroxychloroquine is used for the prevention of COVID in people with diabetes, we have to rearrange the therapy according to the increased risk of hypoglycemia. So in conclusion, people with diabetes are more prone to a serious prognosis when affected by COVID-19. Optimizing glycemic control is the key overall treatment in people with diabetes and the COVID-19. The possible side effect of hypoglycemic agents must be considered during the evolution of the disease, and also all the specific aspects of the disease management should be taken into account. For example, the thrombosis should be treated with the specific anticoagulant therapy. Thank you very much.
Thank you very much, Professor Ciriello, for this brief but concise discussion about the management of diabetes during the COVID-19 infection. Let me just ask you a very small question. Can you explain the brittle kind of glycemia, despite being type 2 diabetic patients, other than the effect of steroids and hydroxychloroquine?
Yeah,
the
story of a glycemic control is a very hot topic today. Because also we have in people without diabetes and COVID the appearance of hyperglycemia, which also is not so infrequent in people in ICU as a stress hyperglycemia. One of the hypotheses is that there is a beta cell damage. And also there is an increase of insulin resistance. And it's clear because to control hyperglycemia in people with COVID, you need a very high amount of insulin. No, this is the experience is coming out that there is a very large amount of insulin is needed to control hyperglycemia, meaning that there is a huge insulin resistance. Of course, if you are induced to use corticosteroids because the situation is very serious, what else? Clearly, you worsen the hyperglycemia by definition. Also, you increase insulin resistance, and it's going to be complicated to control hyperglycemia. On the other hand, the steroids now are safely living. There is no discussion. About hydroxychloroquine, honestly, I do not have, evidence in favor against hydroxychloroquine. One of the hypotheses published some months ago is that probably to be effective, it must be used at a very early stage of the disease to prevent, because the hydroxychloroquine, in the case of a COVID infection, can work reducing the the possibility of the virus to link to the receptor. So clearly you need this action at the beginning of the disease, otherwise it's too late. If somebody is already seriously sick, how can you reduce the infection? The infection is already there. The problem is how early you can use, you must use. This nobody knows. Because, and I think that in terms of prevention, we do not have the right trials, because we have to treat a lot of people to wait to see what happens. But for sure, it's a risky drug, because it can induce hypoglycemia. And when using diabetes, you must adapt the therapy in order to avoid this risk of hypoglycemia.
Maybe also the type of feeding in the ICU actually produces many changes up and down during the management of the patient.
I think, unfortunately, I have to say, I'm sorry to be impolite, that probably even it's well known that the control of hyperglycemia in ICU is very important. It's a huge literature. There are guidelines, but probably the colleagues are more oriented to save the lives than to, what I mean, they have several other problems in acute situation, and they do not pay attention. But at the end of the day, the data are there. Good control of glycemia also saves life. So it's time to pay attention also to it.
Thank you, Professor. And we should now move to the next speaker, introduced by Professor Khalifa Abdallah.
Good evening, everyone. It's really my pleasure to introduce our next speaker, Professor Donia Katerinoui. I'm sorry if I can't pronounce the name. She's a member of the EASCD Diabetes and Cardiovascular Working Group. She's going to talk about very, very important topic today, because we usually face this problem now, is how to manage diabetes in the intensive care unit during the COVID-19 era. Please, Dr. Donia, go ahead.
Thank you very much. I want to thank you, the Egyptian Diabetes Society, for inviting me at this important meeting. And thank you, Professor Ceriello, for bringing me in such an important event. Yes, it's very important what happens with patients with diabetes when they arrive in intensive care units. And it is a difficult problem, and always difficult problems has to be resolved by women. So I will try to do this. From January 2020, we have been facing an outbreak of coronavirus disease, which has now become a catastrophe. Data from early months of 2020 suggests that most people with COVID-19 have comorbidities, and the most frequent are, of course, diabetes and cardiovascular disease and hypertension, with worse outcomes in people with these comorbidities. Depending on the global region, 20 to 50% of patients in the coronavirus disease has diabetes. I will not insist in this slide because Antonio Masterful presented it, but I only want to show that in patients that are admitted in intensive care unit, most often they have thrombosis and multi-organ damage. Why this association between diabetes and COVID-19? For two important reasons. People with diabetes have an increased risk of infection because of their innate immunity defects and because of increased cytokines. In April 2020, a consensus was published on COVID-19 and metabolic diseases that provide recommendations for both outpatients and inpatients For those hospitalized, there are two types of recommendation. Some for patients with COVID who have hyperglycemia, because unfortunately this happens very often. And the second for patients with COVID, with COVID-infected diabetes, and it also contains some therapeutic aims referring to plasma glucose concentration, hemoglobin A1C, CGM, time in range, and hypoglycemia. Also, Antonio presented this slide, but he said that he will present the problems back of the slide. I will present something that it is related with my subject. In the pandemic COVID-19, people with diabetes have a high risk to require intensive care admission, and the management in this case is always challenging. A specific management based on the assessment of the related cardiometabolic status and cardiovascular risk factor can predict adverse outcome. An assessment of the risk factor associated with diabetes is absolutely necessary at the admission. In the case of high-risk patients, cardiovascular status and comorbidities are evaluated, and the opportunity for retention in the intensive care unit is decided. The therapeutic approach also is different for those in intensive care compared to other patients in terms of treatment with diabetes especially, but also the treatment for hypertension and COVID-19. What are the possible issues in the management of people with diabetes and COVID-19 in intensive care are related with metabolic control, with biomarkers, and hypertension. Regarding glycemia, it is necessary to maintain a good glycemic balance without glycemic variation, avoiding hyper or hypoglycemia. Biomarkers are also important, but their evaluation should be done with caution because, in general, patients with diabetes may have markers of inflammation. Blood pressure control is also important because hypertension is one of the most common comorbidities associated with COVID-19 and can fundamentally change the course of the disease. What should we be evaluated in patients with diabetes and COVID-19 hospitalized in intensive care unit? Of course, as I said, glycemic control, hypertension, evaluation of biomarkers, and I'm referring to biomarkers of cardiovascular disease and heart failure, thrombosis and inflammation markers, lipid and statin use, and of course, to evaluate type 1 diabetes. As we know, diabetes is an established risk factor for significantly elevated mortality rate for chronic disease, including infection due to poor glycemic control and chronic hyperglycemia. Some studies show that fasting hyperglycemia was strongly correlated with mortality in patients with or without diabetes. In a recent study, fasting blood glucose at admission is demonstrated to be an independent predictor for mortality in patients with COVID-19 without previous diagnosis of diabetes. Patients with fasting blood glucose under 6.1 millimoles per liter had a lower mortality, 10.6, comparing with 30% in patients with fasting plasma glucose more than 7 millimoles. Also, the risk of complications doubles when the value of basal blood glucose exceeds 7 millimoles per liter. This explanation maybe showed why increased risk of infection is unfavorable in patients with chronic hyperglycemia. Chronic glycemic imbalance further darkens the prognosis in this patient. In the same study, a score for assessing severity of pneumonia is calculated, is called CRB65, and this score includes confusion, respiratory rate more than 30 per minute, systolic blood pressure less than 90 or diastolic blood pressure less than 60, and age more than 65. A CRB of 0 means mild, 1 to 2 moderate, and 3 to 4 severe pneumonia. And as we see, the fasting blood glycemia together with this score can predict the evolution of the viral infection, which is very important. The highest mortality correlates first with a CBR score more than 0, but the highest is the correlation between CRB more than 0 and greater high blood sugar. Which are the reasons for this glycemic fluctuation in patients with diabetes? The first is, of course, fear, anxiety, and tension related with the disease. Then the inflammatory cytokines, the use of glucocorticoids in the treatment of COVID, the stress condition related to infection, which induce glucocorticoid secretion. It is a target stratification of glucose management because glucose management is essential in patients from intensive care unit. For critical patients or patients with organ dysfunction, we have to set up low control target for glycemia. And this is between 7.8 to 10 millimoles per liter. For the rest, we should set a personalized therapeutic target based on comorbidities, patient age, but what is important is that we have to avoid hypoglycemia. Glucose management strategy are different in different type of diabetes. And as you see, if we speak about type 1 diabetes, or if we speak about type 2 diabetes or secondary diabetes, insulin is the best option in most of the cases. Insulin treatment for critical ill patients has become a standard of care, but efficacy might well vary with different intensive care units. For patients in the intensive care unit, the recommendation is to stop all oral glucose-lowering agent and subcutaneous insulin and switch to intravenous insulin using a perfusion device to arrive to a blood glucose of around 140 or between 140 and 180 milligrams per deciliter. However, studies on intensive insulin therapy of critically ill patients show that this treatment could reduce morbidity, but no mortality, unfortunately. If we refer to background anti-hyperglycemia therapy, a challenge in managing hypoglycemia during the stay in the intensive care unit is the background anti-hyperglycemia therapy. DPP-4 inhibitors, CGLT2 inhibitors, pioglitazone, metformin, and short-acting GLP-1 receptor agonists. Their action ends shortly after they are stopped, so they are accepted in the mild form of the diseases, but the patient needs a special care. Long-acting insulin and long-acting GLP-1 receptor agonists are not accepted. Going further to CGLT2 inhibitors, seems that these patients have a high risk of dehydration and diabetic ketoacidosis. Renal function should be carefully monitored for acute kidney injury that can appear early in the evolution of the infection. They require optimal hydration because we have to avoid hypovolemia and electrolyte imbalance, and of course a proper adjustment of insulin doses because the risk of diabetic ketoacidosis with this class of drugs. So patient should stop taking the drug in case of serious illness. Referring to glucagon-like peptide-1 receptor agonist, dehydration is likely to lead a serious illness, so the patient should be very closely monitored. And it is important to look at the fluid intake and regular meals, that we should encourage the patient to do this. Anyhow, in severe cases, patients should stop taking the drug, as I said, in case of serious disease. Concerning the specific therapy for COVID-19, the first class is glucocorticoids, and as Antonio said, seems that they are very useful. They improve the prognosis of COVID-19, but they induce or worsen hyperglycemia, and keeping normal glycemia in this patient may be very challenging. Hydroxychloroquine is controversial indeed, but sometimes is used for preventing SARS-CoV-2, but there are not studies to sustain this administration. Hydroxychloroquine has proven hypoglycemic effect. Therefore, in this case, the insulin treatment must be very carefully managed in order to avoid hypoglycemia. Concerning the monoclonal antibodies, unfortunately, optimal COVID infection management is not achieved during hyperglycemia in both diabetic and non-diabetic person. Other therapeutic approaches are referring to proper hydration, which need increased attention because hyperhydration can induce a pulmonary edema due to the severity of lung damage. Also, kalium level is important with a major risk of hypokalemia, which is frequently associated with COVID-19, possible due to hyperaldosteronism caused by elevated angiotensin II. Insulin treatment may worsen hypokalemia if not corrected in time. Concerning the hypertension, here is a meta-analysis of 8 studies shows that hypertension is the most frequent comorbidity in people with a worse prognosis for COVID-19. And along with hypertension, we see again diabetes, cardiovascular disease, and respiratory system distress. Concerning the strategy for hypertension, we know that most patients with high blood pressure are treated with the two classes of drug, ACE inhibitor and ARBs. So the management of hypertension is a key issue, particularly in the presence of diabetes and COVID-19. This issue about management of blood glucose is related to the possible effect of ACE inhibitor and angiotensin receptor blockers in favoring a worse COVID-19 outcome, particularly in diabetes. The problem was raised by the evidence that SARS-CoV-2, as we know, use ACE2 receptor to enter into the host cell, particularly pneumocytes, and because both these classes can increase ACE2 expression, this drug, it was a hypothesis that can potentially indirectly facilitate the penetration of the virus into the cell. And scientific society and also the European Medicine Agency made a clarification pointing out that no evidence was available to justify stopping the use of this drug. Therefore, recent data show not only the safety of both classes of drug, but also a potential benefit of them. If we speak about biomarkers, severe infection with SARS-CoV-2 can precipitate a myocardial infarction, myocarditis, heart failure, arrhythmia, as well as an acute respiratory distress syndrome. It exerts a direct vascular, endothelial, and myocardial injury and an extensive pulmonary infection. Systemic pro-inflammatory stimulation, known like cytokine storm, hypercoagulability, and increased sympathetic stimulation, and also hypoxia in the context of acute respiratory distress syndrome can induce a very complex process. Most of the complications are related to biomarkers, especially high C-reactive protein, HS troponin, brain natriuretic peptide, and D-dimer, which have been shown to be associated with a more severe, if not fatal, outcome of COVID-19. Increased levels of these biomarkers and inflammatory cytokine have been reported to be present in diabetes independent of any concomitant infection. This may imply that the use of these biomarkers to follow the evolution of COVID-19 in people with diabetes needs a careful evaluation. Anyhow, anticoagulation was linked to decreased mortality rate in COVID-19. Concerning the lipids and statin use, most of patients are on lipid-lowering treatment. We know that statins have an anti-inflammatory effect and can improve endothelial function, which may be protective against cardiovascular complication. Similar to renin-angiotensin and aldosterone system blockers, experimental studies showed that statin also increased ACE2 receptor expression. Whether statin may be beneficial or harmful during virus-induced acute respiratory distress syndrome is controversial at this moment. Concerning the type 1 diabetes, yes, it is real people with type 1 diabetes are not more exposed to SARS-CoV-2 infection and nor to more severe outcomes compared to patients with diabetes type 2. But in patients with diabetes type 1, it's more complicated to manage the insulin treatment, and probably they need a special attention when admitted to intensive care unit. In conclusion, we can say that the ongoing COVID-19 pandemic is taking a heavily toll worldwide, and effective measures have to be taken to minimize its impact and lower mortality. Adherence to current guidelines for the prevention of cardiovascular disease in diabetes is one of the urgent actions, along with good metabolic control. The complex pathology is challenging for the use of most diabetes medication because of contraindications that need close monitoring of all people with diabetes and SARS-CoV-2 infection. Thank you very much for your attention.
Thank you very much, Professor. Donia or Donita? Donita.
Doina. Doinita is Doina. It's okay, Doina.
Thank you very much, Professor Doina, for your elegant presentation. I just want to comment that it seems that management of diabetic in intensive care unit, it has the same principle, whether in COVID or non-COVID, some similarities, that we used to use an intensive care unit only insulin by verified protocols, variable rate insulin infusion protocol. Our goal always is 140 to 180 milligram per deciliter. Usually, even with myocardial infarction, with any stressful situation, the fasting blood glucose at admission is really related to outcome, even in non-diabetic. It seems that it reflects the severity of the condition itself, leading to hyperglycemia, maybe. However, what is the difference when we manage a diabetic patient in intensive care unit with COVID disease versus other critically ill conditions? I mean, there is some suggestions that we have to do the contact between the healthcare professional and the patient less frequent. That's why some suggest that in mild to moderate cases, for example, of ketoacidosis, diabetic ketoacidosis, we can use subcutaneous insulin injection every 4 hours. That's why we don't have to touch the patient hourly, I mean. And there is some results that this can be okay, except, of course, in severe diabetic ketoacidosis the other way. How about the continuous glucose monitoring? Because most of our clinical intensive care units are not acquainted with this device, and there is some suggestion that we can use it in intensive care unit with COVID disease. What is your comment regarding your experience with these maneuvers?
Of course, it's very difficult to manage a patient with diabetes, with hyperglycemia and a COVID-19 without infusion of insulin. Because, as you say, you have to be very close to the patient and make a lot of tests. And this is not very good. On the other hand, it is a narrow way, because they don't have to experience hyperglycemia, but they don't have to experience also hypoglycemia. So, of course, we use infusion of insulin here, but the collaboration is a little bit difficult because patients with COVID-19 are in a special hospital where it's not a diabetologist, and keeping close to the patient is more difficult. But I think that it's very important to evaluate very well the patient from the beginning, because the complications which usually appear in the second week can surprise us. So glycemic control is our problem, and we have to face it very well. And if it is possible, not to arrive with a patient in the state of ketoacidosis. At least if they have hyperglycemia, as you say, they can use subcutaneous insulin, and of course, it's better not to make severe changes in the treatment if you are not forced to do this. But as I say from the beginning, this kind of patient is very difficult to manage, and unfortunately, they have a high mortality if they associate cardiovascular disease. And let's say that the team has to be with more doctors, cardiologists, diabetologists, a doctor for infection disease, and yes, it's difficult.
Okay, thank you very much. Thank you very much for your talk. And now I leave the floor for the next presentation. Professor Ibrahim Al-Ibrashi, please take the mic.
Bismillah ar-Rahman ar-Rahim. I'm so pleased that today we have a long day, and actually the second wave of this meeting with European Association of Study of Diabetes, especially the group of cardiovascular disease and prevention. Now we're going to present Professor Salah Shilbaya. He's Professor of Internal Medicine and Endocrinology at Ain Shams University, and he is the moderator of this 2 days meeting. He'll talk about recent updates in type 2 management, role of DP4 inhibitor in current treatment paradigm. Professor Dr. Salah.
Thank you, Professor Ibrahim, for this kind introduction. As you see, I will talk about the role of DPP4 inhibitors in current treatment paradigm after the recent guidelines. So as we see, this disease, type 2 diabetes, is progressive and the number increasing by time. And here we see that the number will be 108 million in 2045 patients. This is a very important slide I would like to present to clarify the number of patients with diabetes with cardiovascular disease. If we look at the time of diagnosis, we will see that we have about 62.9% have no cardiovascular disease and no chronic kidney disease. Only we have cardiovascular disease and the chronic kidney disease by about 8.6%, and alone cardiovascular disease in 13% without chronic kidney disease. So we can say that the total cardiovascular disease will be about 21.6%, and the total chronic kidney disease will be 24.1%. I mentioned this figures in order to, when we are going to start our treatment or to start the second step in the treatment, which drug we have to choose and which drug we have to prescribe for our patients. And this is the fact that the majority of type 2 diabetic patients are not at HbA1c goal in most of the countries. And the clinical inertia in type 2 diabetes management is very important issue. We have to see here the figures in all patients, and the patient who has HbA1c from 7 to 8 and from 8 to 9 and even more than 9, you will see that even in more than 9, the clinical inertia is more. As to say, they wait for many long times to add in another drug for intensification. That's to say, most alarming was the finding that even in this group, among patients with the highest index of HbA1c category of 9 or more %, therapy was not intensified in 44% of these patients. We have, we know early that higher HbA1c is associated with increased microvascular complications as well as the increase of macrovascular complications. So delay in treatment intensification increase the risk of cardiovascular events in patients with type 2 diabetes. As you see here, it's not no proof for cause and effect relationship, these figures. MI by 67%, stroke 50%, heart failure 64%, cardiovascular events 62%. The key published studies demonstrating كلها the safety and the tolerability of DPP-4 inhibitors, as we see for allogliptin, linagliptin, saxagliptin, sitagliptin. All these cardiovascular outcome studies already showed the safety or the safety for cardiovascular complications. Only for examined study for allogliptin, it shows numerical increase for hospitalization for heart failure, but was not significant. And SAVOR showed significant increase for hospitalization of heart failure. But for TICOS study, which was done for the sitagliptin, we all know that it is very safe, no increased cardiovascular risk compared to placebo. And also we see that there is no increase in hospitalization for heart failure, either numerically or significantly. When we look for the new class, the sodium glucose cotransporter 2 inhibitors, the major cardiovascular outcome studies, EMBA, CANVAS, and DECLARE study, they all showed the safety for cardiovascular outcome results. For the MACE, which is the 3-point MACE. And if we look here, we will see that EMBA-REG is the best of them. CANVAS also looks like very beneficial for canagliflozin. And DECLARE showed neutrality for this effect. For heart failure, it's very important that all molecules of SGLT2 inhibitor, they show a very good beneficial effect in reducing hospitalization for heart failure. But if we look for the patients with multiple risk factors, there is no significant difference favoring this class for the patients with multiple risk factors as shown in the CANVAS and in the DECLARE. Heart failure, as I said, all molecules are very important treatment for decreasing the hospitalization of heart failure. But we can say after these two slides that for the majority of type 2 diabetic patients without history of atherosclerotic cardiovascular disease, no drug proven till now to show cardiovascular benefits. So what should you consider first for a type 2 diabetes after metformin therapy, which will be discussed tomorrow in the second day of our second wave? We have to choose the drug according to the different points as we see here. The glycemic efficacy, what is the hypoglycemic risk of this drug, its effect on weight, possible benefits, adverse effects, tolerability by the patient, the presence or absence of comorbidities, and also this is very important, patient reference, and finally the cost. We all know that the place of DPP-4 inhibitors in current diabetes management guidelines after this new cardiovascular outcome trials, it's present in the whole situation. As you see here, if we go to the column of the patients with atherosclerotic established disease or have chronic kidney disease, they are present here to be added. And if there is no atherosclerotic cardiovascular disease or chronic kidney disease, they are present from the start after metformin therapy. So choosing glucose-lowering medication, if compelling need to minimize hypoglycemia, we have to look for the drugs with very low risk of hypoglycemia. And I think the the first group is DPP-4 inhibitors, which has very low risk of producing hypoglycemia. And as we know, as I said before, that the with atherosclerotic cardiovascular disease or chronic kidney disease may contribute about 30% of patients at the beginning of the disease, and we have almost about 60 to 70% of patients without these two complications. So we can very safely add from the start after metformin DPP-4 inhibitors. Of course, there is another drugs which has very minimal risk of producing hypoglycemia, like GLP-1 receptor agonist, SGLT2 inhibitors, and also TZDs. We have to discuss with our patient which drug he prefer after clarifying for the patient each mechanism for the drugs and the relation to weight, to hypoglycemia, and to the cost, of course. Sitagliptin as one of these molecules, DPP-4 inhibitors, plus metformin gives a very good complementary effects on insulin release from the pancreas, glucagon secretion, and glucose output, and also the insulin resistance. And that's why if we look at this slide, we will see that in patients who have a very high baseline HbA1c, they have also a very significant reduction of the HbA1c by about 3.6%. And this efficacy, this effect of the sitagliptin remain for, it's very durable for the week 30, was non-inferior to that of a very strong sulfonylurea molecule. We all know the glimepiride, as you see here, and maybe by time, or if you increase the duration, you will get more significant results in maintaining this efficacy and reducing the HbA1c after 5 years. This is a comparison between sitagliptin and dapagliflozin. It showed here a greater reduction in HbA1c at week 24. This is published in Diabetes, Obesity, Metabolic at 2018. It shows more reduction of HbA1c by using sitagliptin versus dapagliflozin. And also there is higher incidence of, in this study, congenital mycotic infection. Of course, this is clear. We all know that the group of SGLT2 inhibitor increase incidence of mycotic infections, especially in female. Sitagliptin was associated with a lower incidence of hypoglycemia and reduced body weight versus glimepiride. This is very well known that hypoglycemia are higher with all sulfonylurea groups and very minimal with DPP-4 inhibitors. And this slide shows the difference in patients with hypoglycemia between the glimepiride group and the sitagliptin group. And also regarding the body weight change, we know that sitagliptin as a molecule of DPP-4 inhibitors, they all have neutral effects on body weight, but sometimes we notice a reduction in body weight of patients using this molecule. Sitagliptin pooled safety analysis shows very importantly the similar rates of everything if we compare it with placebo regarding cardiac disorders, infections, bone fractures, angioedema, and malignancy. And if we look for the role of sitagliptin in different patients, as elderly patients and renal patients, liver disease, and patients who need insulin, what we will see in old age, sitagliptin used in elderly shows very safely. Patients who are more than 65 years were comparable to those seen in younger patients, less than 65 years. And there is no dose adjustment based on age of the patient. Elderly patients are more likely to have renal insufficiency, as with other patients. Dosage adjustment here may be required in the presence of significant renal insufficiency, as we will see in the next slides. Group of patients with renal impairment, we have a patient, if he has normal renal function, we give the whole dose of the drug, which is 100 milligram per day. If there is mild renal insufficiency, creatinine clearance is more than 50, we will give also the whole dose. In case of moderate renal insufficiency, between 30 and 50 GFR, we will give the half dose, 50 milligram once daily. In severe renal insufficiency, we can use 25 milligram once daily, also in patients requiring dialysis or have end-stage renal disease. The efficacy of the sitagliptin is similar in renal function regardless the severity of the case. This is the normal renal function. So mild renal impairment, moderate to severe, and end-stage renal disease. All patients have a reduction of their HbA1c of about 0.7 to 0.8%. What about patients with liver disease? As we all know, we consider this as a special population. There is no adjustment necessary for patients with mild to moderate hepatic impairment. But however, patients with severe hepatic impairment, there is no evidence that we can use this molecule. Finally, what about patients which need insulin? Can we use sitagliptin with these patients? This study showed already the use of sitagliptin plus insulin in patients with type 2 diabetes. We will notice two things which is very important. We will notice that insulin dose will be significantly decreased, and we will see that there is a change from baseline fasting plasma glucose significantly after with use of sitagliptin with insulin. This is the EMA announcement using in different population. Sitagliptin can be used in mild to moderate hepatic impairment, severe hepatic no, mild to moderate renal impairment we can use, severe renal we can use, end-stage renal we can use, and elderly above 65 years also we can use. Thank you for your attention. Professor Ibrahim.
Thank you, Professor Salah, for your elegant presentation. Actually, we are talking about one of the medications or group of medication we are using more than 10 years now. The safety profile and the efficacy-wise, we are all know that. Just one question, short question. Now we are talking about could we have the benefit of DPP-4 inhibitors in the treatment of diabetes during the COVID-19 in mild to moderate cases, as you today are talking about a lot about treatment of diabetes in the era of COVID-19.
I get an impression from many weeks, many months, has been given the start of this COVID that type 2 diabetic patients, if they have COVID-19 and they are in a moderate case or mild case and not need hospitalization, I think they can use their usual drug which they are on as long as they are controlled. And of course, DPP-4 inhibitors are very important in this issue. But for these patients who will be admitted to ICU or have a severe disease, I think insulin therapy is the choice.
Thank you, Professor Salah, for your elegant presentation. Now I'm going to shift to the last session today. Professor Dr. Samir.
Good evening, ladies and gentlemen. It's really a pleasure to chair this last session of this very important scientific day, presenting Professor Ibrahim El-Ibrashi, head of the Internal Medicine Department, Cairo University, who is going to end the session by talking about the SGLT2 inhibitors, the comprehensive type 2 diabetes management. And as we see from the previous session, we are talking about the DPP-4, and now we are going to talk about the SGLT2. And we are in the continuous dilemma, what is the best after metformin, what is the best to be treated? And I think that very wise doctor decision is the most important thing with the patient to choose the ideal treatment. I think that Professor Ibrahim is going to clarify this point. Professor Ibrahim, تفضل.
Thank you, Professor Dr. Samir, for your presentation. Actually, Professor Salah talked about one of the very famous groups is DP4 inhibitor. Today, I'm going to talk about the newest groups already now become more famous, the SGLT2 inhibitor in the management of type 2 diabetes. We all know that actually the burden of type 2 diabetes is increasing worldwide. And this is the latest atlas of International Diabetes Federation, talking about we nearly more than 460 million diabetic patients globally, but still we have 2 times increase in the likelihood of cardiovascular disease, including coronary, cerebrovascular, and also we have 10 times increase of the end-stage renal disease in patients with diabetes. So diabetes actually is not just treatment of controlling of hemoglobin A1C, but we need to reduce this complication. We found that type 2 diabetic patients at increased risk of microvascular complication, which is one of the famous problems. It is a famous triopathy of diabetes, nephropathy, and retinopathy and neuropathy. It nearly more than 50% of diabetics within 10 years will have a microvascular complication. What about a myocardial infarction? 54% are increased risk of non-fatal MI during the 5.5 years compared to those without diabetes, and 72% increase risk of ischemic stroke and in comparison to patients without type 2 diabetes during the 5.5 years. And very important is the 33% increased risk of hospitalization for heart failure within 4 years of diagnosis of type 2 diabetes. So we have a problem. Not only you have to control hemoglobin A1C, but we have to manage to reduce the complication from this type 2 diabetes. Heart failure now was the first manifestation discovered to be in type 2 diabetic related cardiovascular disease, even more often than that of myocardial infarction and stroke. They found in a large cohort study of patients, nearly reaching 2 million patients with type 2 diabetes and incidence of cardiovascular disease. We'll see here that on top is a peripheral arterial disease followed by heart failure, more than non-fatal MI or cardiovascular or stroke or cardiovascular deaths. And still, most of the data are rising from the FDA for requirement post-marketing study to putting the myocardial infarction and stroke as a continuity for primary outcome in all cardiovascular trials, trying to reduce the myocardial infarction, the fatal stroke, and even non-fatal MI and non-fatal stroke. But still missing the peripheral arterial disease and heart failure as a primary endpoint in the cardiovascular outcome trials. Diabetes leads to heart failure through 2 pathways, either atherosclerotic mediated or non-atherosclerotic mediated or atherosclerotic independent mechanism. Atherosclerotic, definitely yes, like increasing incidence of myocardial infarction, which will end by increasing the heart failure with reduced ejection fraction because of myocardial wall damage. On the other side, atherosclerotic independent or not related to atherosclerotic problem. Also, these patients are at risk for heart failure to direct inflammatory microvascular effect on the myocardium. At the end, these 2 pathways, either atherosclerotic mediated or non-atherosclerotic mediated, will end by heart failure. In type 2 diabetes, that's one of the early complications of type 2 diabetes is the left ventricular dysfunction. All of us, for a long time, we see an echocardiography reports. We have a diastolic dysfunction, and at that stages, the importance of this diastolic dysfunction, different grades of it, what was the significance, nobody was noting at that time, or they're not alarming for any diabetologist. They found that 68% of patients with type 2 diabetes had evidence of left ventricular dysfunction within 5 years after type 2 diagnosis. And the diastolic left ventricular dysfunction in nearly 16%, the systolic left ventricular dysfunction in 27%, combined both of them in 25%. So we are left only by nearly 30% with normal left ventricular function. These two distinct phenotypes of diabetes-related cardiomyopathy exist: heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. The heart failure with preserved ejection fraction occurs as earliest. It is the problem of cardiomyocyte hypertrophy, fibrosis, and increase in the cardiomyocyte stiffness, which leads to diastolic dysfunction. The heart failure with reduced ejection fraction, we have a cardiomyocyte apoptosis, necrosis, and decreased cardiomyocyte shortening. So we have an ejection fraction reduction. We have the systolic functioning disturbed. So these suggest that the earliest defect in diabetic heart is the diastolic dysfunction, not the access thrombosis, which will be ended by this. Also, when we come to the microvascular complication, especially nephropathy, it occurs early in the disease. They found that individual patients with screening detected for type 2 diabetes or any diabetic patient who were newly diagnosed underwent assessment for microvascular complication. You will see here that the top is the neuropathy and followed by the microalbuminuria, even more than retinopathy. So we are talking about 30 to 40%, even more than 40%, either nephropathy or neuropathy. So we have a problem, even the starting diagnosis of type 2 diabetes, we have some form of microvascular complication, mainly neuropathy followed by nephropathy. There is a direct relation, close interaction between diabetes and what happens in the kidney and what happens in the heart. Diabetes leads to sodium retention, hypervolemia, RAS activation, neurohormonal activation, inflammation, ischemia, all of them cyclically related to either the kidney or the heart problem. So renal and cardiac system should be considered, both of them occurring together. So it's very important. We all know since a long time that patients with renal problems, they have the markers for widespread microvascular complication and even coronary artery disease. So come the pathophysiology defects, since Professor De Franzo mentions the ominous octet. We have a lot of pathophysiological defects working either alone or with each other in occurrence of type 2 diabetes. Today, we're going to go to work or to talk about the increased glucose reabsorption of the kidneys. Why the SGLT2 inhibitors are different? In normal renal glucose handling, we found that 90% of glucose is reabsorbed by SGLT2 receptors in the proximal part of the proximal tubules. And the only remaining glucose reabsorbed is the SGLT1, which is the distal part of the proximal tubules. So we have 90% of the reabsorption of the filtered glucose reabsorbed in the proximal part of the proximal tubules through the SGLT2. And this leads to a minimal or even no glucose excretion in the urine. What after using of SGLT2 inhibitor like dapagliflozin, it inhibits this SGLT2, which is responsible for 90% of the reabsorption of the filtered glucose, leaving removal of excess glucose, removing it in the urine, so inducing glycosuria. That's only this work. It also found that in diabetics, they found that the renal glucose reabsorption occurs at a threshold higher even in the normal population. Normal population, if the threshold exceeds 180 milligrams per deciliter, glycosuria starts. In diabetics, even reaching to up to 240 milligrams per deciliter in the blood, still glycosuria does not appear. The use of SGLT2 inhibitor not only reduces the glucose reabsorption, but it also reverses, even improves the renal reabsorption of glucose, preventing the renal absorption of glucose up to the normal, even below normal, up to 75 milligrams per deciliter. So it's not only working or inducing glycosuria in the normal levels, reported in even diabetic without diabetics, but also it prevents reabsorption even in blood glucose reaching up to 75 milligrams per deciliter. Why these SGLT2 inhibitors are different? They are working in insulin-independent pathway. They found that it reduces glucotoxicity by inducing glucose excretion directly which this improvement in glucotoxicity, improving beta cell function, which is occur indirectly, and even improving insulin sensitivity. The reduction of blood glucose reaches up to 2.6% in hemoglobin A1C from baseline if you are working on hemoglobin A1C nearly or equal or more than 10%. They found the effect of usage of dapagliflozin, one of the SGLT2, on the tissue sensitivity to insulin and even beta cell function improvement in patients using dapagliflozin for 14 days led to 25 to 30% improvement in muscle sensitivity to insulin, which and also improvement in twofold increase in beta cell function. This improvement in both parameters are nearly mediated through amelioration of glucotoxicity, thus reducing plasma glucose concentration, secondary to glycosuria, and contributing to the improvement in overall glucose homeostasis. Are they effective? We are talking about first, are talking about anti-diabetic medication. Are they an effective medication in all across broad range of treatment, consistent with hemoglobin A1 reduction and over a number of combination? One uses the monotherapy is dapagliflozin, 10 milligrams, or even add on to metformin, add on to sulfonylurea, add on to a triple therapy of DPP-4 inhibitor and metformin, add on to insulin and plus or minus other oral medication, add on to metformin and sulfonylurea. So in a monotherapy or dual therapy or even triple therapy or even with insulin therapy, all of them showed definitely reduction, hemoglobin A1C reduction more and more than compared to either monotherapy or dual or triple therapy. In the monotherapy, dapagliflozin 10 milligrams in patients with hemoglobin A1C, as I said before, equal or more than 10%, after 24 weeks of usage of dapagliflozin 10 milligrams, they have a reduction of hemoglobin A1C by 2.6%. The higher the hemoglobin A1C at the beginning of the treatment, the higher drop of hemoglobin A1C. What about the expectation comparing the reduction of hemoglobin A1C, the reduction in fasting or 2 hours postprandial of SGLT2 versus DP4 inhibitor, one of the famous groups you are using? The one compared to DP4 inhibitor, the dapagliflozin provide an extra benefit beside hemoglobin A1C reduction when they used dapagliflozin 10 milligram plus metformin extended release versus saxagliptin 5 milligram versus plus metformin extended release. They found more reduction on hemoglobin A1C, and at the same time, which is very important, more weight loss with no changes in hemoglobin by 2.4 kilograms, and also reduction of systolic blood pressure by 0.3 millimeter mercury, then by 3.5 millimeter mercury versus only 0.3 millimeter mercury with saxagliptin. So we have nearly the same benefit or a little more reduction in hemoglobin A1C, and also at the same time we have more weight loss by 2.4 kilos and more reduction in systolic blood pressure by 3.5 millimeter mercury. What about the fasting and the 2 hours postprandial blood glucose? When comparing saxam plus metformin versus dapagliflozin, we have doubling reduction in fasting blood glucose and in 2 hours postprandial blood glucose. Have done the fasting and hours blood glucose and compared with DP4 inhibitor, both of them add on to metformin therapy. What about the comparison with the famous potent medication we long time using more than 60 years, the sulfonylurea? In this study, when dapagliflozin when added to metformin versus sulfonylurea when added to metformin, we are talking about combination therapy, they found no difference in hemoglobin A1C reduction, and we are talking about non-inferiority to one of the famous glipizide, one of the famous sulfonylurea. So as potency, it is comparable to sulfonylurea, a little bit higher than DP4 inhibitor, at the same time with less weight, even weight reduction and reduction of systolic blood pressure. What about the important item now? We are talking not only on controlling of hemoglobin A1C, controlling hyperglycemia. What about beyond this glycemic control? When we are talking about the pump, the pipes, and the filter, are the SGLT2 inhibitors cover it all? When we're talking about pound, or we're talking about diabetic cardiomyopathy, the coronary artery disease in the pipes, and the filter, which is very important, is the chronic kidney disease. A lot of very famous big mega trial was the first one presented to improve the cardiovascular outcome in diabetic type 2 diabetic patient was the cardiovascular trials of the SGLT2 groups. One of the empagliflozin is the EMPA-REG trial, the canagliflozin, the CANVAS, and the dapagliflozin is the DECLARE, are different in different population. And in patient with EMPA-REG, 99% was established cardiovascular disease. In the CANVAS trial, the canagliflozin, the type 2 diabetic was established in 66% or 3 or more cardiovascular risk factor in 1/3 in 34%. The DECLARE was 41% was established and nearly 60% with or 2 or more cardiovascular risk. So we are talking about secondary prevention and completely in the EMPA-REG, CANVAS, partially secondary prevention and little primary prevention. The DECLARE is mainly primary prevention and little secondary prevention. When we talk about the population in the 3 trials, the EMPA was 7,000, nearly 7,000 patients. The CANVAS program was 10,000 patients. The dapagliflozin, the DECLARE, were 17,000 patients. And the follow-up years were more in the dapagliflozin, 4.2 years, in the CANVAS 3.6, and in the EMPA is 3.1. As we said before, the patient with atherosclerotic, nearly most of them or all of them in the EMPA, so 1/3, 2/3 in the canagliflozin, and only 40% in the DECLARE study. Here is very important is the renal impairment. Only 7% of cases in the dapagliflozin, 20% in the canagliflozin trial is the CANVAS, and 26% in the EMPA-REG is the empagliflozin. The DECLARE was the largest and broadest SGLT2 inhibitor cardiovascular outcome trial, recruiting patients with and without established atherosclerotic cardiovascular disease. In comparison, as I said before, for the CANVAS or the EMPA-REG, EMPA is completely secondary, the CANVAS is partially mainly secondary and 1/3 primary, and the DECLARE nearly 50-50. When you are talking about the proportion of patients with preserved renal function compared to the EMPA or CANVAS, you will find here in the according to estimated GFR category, all of them is the DECLARE study had the lowest renal problems among these 3 mega trials. In patients with estimated GFR from below 60, only 7% in patients with DECLARE. In patients from the estimated GFR from 60 to 90, only 45. On the CANVAS was higher, and patients and more than hemoglobin mainly 48% in patients with DECLARE. So the patient with impaired kidney function are the least in the study of the DECLARE. What about the primary efficacy endpoints? They was putting 2 primary endpoints. The primary, it's a 3-point MACE, the cardiovascular death, non-fatal MI or non-fatal stroke, and the co-primary endpoints is the cardiovascular death combined with hospitalization for heart failure. When combined, the 3-point MACE, it was non-inferiority to the placebo. On the one you have combined the cardiovascular deaths and hospitalization of heart failure, we found that statistically significant risk reduction by 17% in patients taking 10 milligrams versus the placebo. So on the 3-point MACE, it was non-inferiority. When you combine the co-primary endpoint, the hospitalization or heart failure and cardiovascular deaths, we have a statistically significant risk reduction by 17%. And also, dapagliflozin showed a significant 47% reduction in the occurrence of the renal-specific composite outcomes. What about these effects was achieved even in patients taking RAS blockade, nearly more than 80% of them. What are the specified renal composite outcomes, either reduction of estimated GFR by more than 40% to 60%, and even end-stage kidney disease or renal deaths. This reduction by 47% in the renal composite outcomes. What about the likelihood of patient improving in albuminuria category, regardless the baseline urinary albumin secretion? Whatever a patient with micro to normal, or macro to normal, or macro to normal, or micro, and micro or macro to normal. All of them, they will show that there is significant favoring dapagliflozin of dapagliflozin, so the improving in albuminuria category, whatever the baseline urinary albumin secretion. What about the secondary prevention? We are talking that empagliflozin in the EMPA-REG and CANVAS programs of empagliflozin get improved in the secondary prevention population. When they have studied the patient in the DECLARE study, patient with high cardiovascular risk, type 2 patient with prior MI, so we are talking about secondary prevention, dapagliflozin reduced the MACE by 16% within 4 years. Number needed to treat of 39. In patient with prior MI, patient without prior MI, patient is here, there is differently by 16%. So, well, a patient without MI, there was no difference between the two groups. But patient with prior MI, so yes, it improves in secondary prevention, has clear beneficial effect on MACE outcome in patient with high cardiovascular risk, patient especially with patient with previous myocardial infarction. What about patients with type 2 diabetes and heart failure with reduced ejection fraction? This was a very important item. They found that the cardiovascular benefit of dapagliflozin appears early in DECLARE, as in 10% of patients with already heart failure with reduced ejection fraction. In patients, when we combine the co-primary endpoint, the hospitalization for heart failure and cardiovascular deaths, number to treat within 4 years is 11, by relative risk reduction by 38. When we are talking about hospitalization for heart failure, number needed to treat within 4 years, 18, and with relative risk reduction by 36%. The cardiovascular deaths, number needed to treat, and within 4 years, 19, led to reduction by cardiovascular deaths by 45%, and all-cause mortality, number needed to treat within 4 years, 16, leading to relative risk reduction by 41. Patient with heart failure with reduced ejection fraction, a lot of benefit in reduction in hospitalization for heart failure, cardiovascular deaths, and all-cause mortality. What about the cardioprotective part in primary prevention population, which is also very important item? Is the first one to see what about the primary prevention. The EMPA and the CANA didn't show in the primary prevention, they showed only in the secondary prevention benefit. They found that in dapagliflozin, in DECLARE study, showed prevented hospitalization of heart failure in type 2 diabetic patient with relative risk reduction by 27% with highly significant p-value. So a patient in DECLARE study found that the primary prevention in type 2 diabetic patient population reduction in hospitalization for heart failure was statistically significant. Even dapagliflozin prevented hospitalization of heart failure, or whatever the broad range of type 2 diabetic patient, regardless they have a history of established cardiovascular disease or even history of heart failure. We'll see here both of them. Heart failure presence or absent in the previous of heart failure, both of them we have relative risk reduction even in patients without previous heart failure and with previous heart failure. On the other side, the patient with or absent established cardiovascular disease, hospitalization of heart failure was more beneficial part in using of dapagliflozin. The patient even with no cardiovascular risk, we see also that there is 36 relative risk reduction for hospitalization of heart failure, whatever the patient has history of cardiovascular disease or not, or the history of heart failure or not. What about the renal benefit? It was demonstrated across whatever the estimated GFR subgroups in patients with and without established cardiovascular disease. What we are talking, why we are talking about with and without, we are talking as primary prevention or secondary prevention. Patient with established, they already are talking about secondary prevention. Patient without established cardiovascular disease, we are talking as a primary prevention. Heart failure, it occurs, it has a benefit, whatever the patient had previously had cardiovascular disease or not. Also here, the renal benefit, whatever the estimated GFR, it have beneficial part, even patient with and without established cardiovascular disease. So we are talking about primary prevention for heart failure and primary prevention for renal, the correction of renal composite endpoints, which more than 40% decrease in estimated GFR to less than 60, or end-stage renal disease, or even renal deaths. So when we're talking about primary prevention, getting through to secondary prevention, we have in the primary prevention either to work about risk factors, and already the atherosclerotic left ventricular hypertrophy, what before I mentioned, leading to whatever disturbance in the myocardial function, ending by myocardial infarction, which will in turn will induces dilatation of the ventricle and remodeling, inducing congestive heart failure and end-stage heart disease and death. So if we can work here, it's better than working here. So whatever you have, you need a primary prevention to reduce at the end is the cardiovascular deaths. What about the cardiovascular, this improvement in the cardiovascular safety and issues when using dapagliflozin in their study? When you see here that in comparison to placebo, that DAPA 10 milligrams, all of them were the same, no difference between the DAPA group and the DAPA arm and the placebo arm, except in the genital infection and UT infection, and even in diabetic ketoacidosis. But about amputation and Fournier gangrene, it is not different between the DAPA and the placebo. So only apart we will know that induction of glycosuria will induce increase in genital infection and UT infection. Apart from this, is no difference between the dapagliflozin and the placebo in the established safety profile of this DAPA. So when going back to the pump, pipes and filter, does SGLT inhibitor cover its own in secondary prevention population? And in the primary prevention population, we have either improve the major adverse cardiovascular events by the DECLARE study, and also already in the part when they analyzed the patient with prior MI. At the same time, whatever this patient is established or without established atherosclerotic cardiovascular disease, there is a reduction of hospitalization, of heart failure, and renal protection. So this important can be implicated for primary prevention, the renal protection and the hospitalization for heart failure, and also the major adverse cardiovascular events in patient with already established cardiovascular disease. This pathophysiological interaction between the kidney and the heart can be explained what is going on in the usage of SGLT2 inhibitor. In type 2 diabetic patient, they increase the cardiac preload and afterload, increases cardiac wall stiffness and stresses, and the same increasing volume expansion and vasoconstriction, systolic blood pressure, and this in turn leads to cardiorenal complication, either cardiomyopathy or heart failure or diabetic kidney disease. When we use SGLT inhibitor, it decreases glucose and sodium reabsorption and interglomerular pressure, intrarenal RAS activity reduced, reducing the hyperfiltration, and reducing inflammation and hypoxia. This induction of glycosuria, diuresis, and natriuresis will reduce plasma volume, arterial stiffness, reduction in systolic blood pressure, and improvement and increase in hematocrit, which in turn had reduced cardiac preload and afterload, reduces cardiac wall stress, increase cardiac efficiency and output, so improve making more cardiorenal protection, improving cardiac function and renal function. And this can be is already found in the cardiovascular outcome trials of SGLT2 inhibitors, either in the secondary prevention, in the IMPA and part of it in the CANVAS program, and the primary prevention in the DECLARE study. A lot of explanation, we can't say which one is working more, but a lot of explanation, the use of SGLT2 inhibitors, how can it improve the heart and the kidney. So, Mr. Chairman, in summary and conclusion, what in the American Diabetes Association standard of care, the treatment medication overall approach, when you are using patient first line still metformin and comprehensive lifestyle management, and indicators patient if not reaching the target, indicator of high risk or established atherosclerotic cardiovascular disease or chronic kidney disease or heart failure, we have to use drugs already, whatever the baseline hemoglobin A1C or individualizing hemoglobin A1C target, we have to use SGLT2 with proven cardiovascular benefit if the estimated GFR adequate to work, not for hazard on the kidney, or patient already has heart failure or chronic kidney disease predominate, preferably use SGLT2 with evidence of reducing heart failure and or chronic kidney disease progression in the cardiovascular outcome trials. Also, it is very important if the estimated GFR is adequate into evidence. At the same time, while we're talking about hypoglycemia, SGLT2 is working as one of the least hypoglycemic medication also in causing hypoglycemia. And already when you are talking about minimizing weight gain is very important. The initiation of SGLT2 inhibitor and GLP-1 receptor agonist, which is a statement get out from the American Diabetes Association, are in patients with are indicator of high risk or established atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure. They said that the usage of the cardiovascular benefits of SGLT2 inhibitors and GLP-1 receptor agonists are not dependent upon a hemoglobin A1C lowering. So this is important. So initiation can be considered in people with type 2 diabetes and cardiovascular disease independent of current hemoglobin A1C or hemoglobin A1C goal. Consider the following: if on dual therapy or multiple glucose lowering therapies, which does not include any SGLT2 inhibitor or GLP-1 receptor agonist, considering switching to one of these agents within these drug classes with cardiovascular benefit, or introduce an SGLT2 inhibitor or GLP-1 receptor agonist in patients with cardiovascular disease at hemoglobin A1C goal for cardiovascular benefit. So the important message, you have to initiate in patients with established or indicator of high risk for atherosclerotic cardiovascular disease or chronic kidney disease or heart failure, SGLT2 inhibitor or GLP-1 should be added irrespective of hemoglobin A1C level. On the end of last year, the FDA got approval for dapagliflozin after the DECLARE study to cut risk for hospitalization of heart failure in type 2 diabetes. As I presented, the primary prevention population, whatever the patient was established or without cardiovascular disease risk, most of them have benefit for reduction of hospitalization of heart failure. So we are talking of primary prevention, which is only approved SGLT2 in primary prevention to reduce the risk of hospitalization of heart failure for patients with type 2 diabetes and established atherosclerotic cardiovascular disease, or even patient with multiple cardiovascular risk. This impacts of these updates either should be on our clinical practice guidelines, what happened in 2020, and we hope also in our patient outcomes. And thank you.
Thank you very much, Professor Ibrahim, for this full comprehensive showing of the role of the SGLT2, because definitely SGLT2 are following very large steps in the control of diabetes. And definitely, I think that one of the important things is that it works outside insulin. It has a strong power of glucose control. It is having an added value apart from the glycemia on the heart failure and the kidney progression. It has definitely a lot of impact, even to the extent that now there are talks to talk about the role of SGLT2 in the treatment of heart failure, even without diabetes. The value of this group of drug, and when you talk about to cardiologists, they are pushing very much the use of SGLT2 in the treatment of heart failure per se. This multitude of things are definitely very beneficial in this group of drug and may make them supersedingly, because even in the ADA guidelines in 2020 or the consensus, even when we talk about the price, it's written at the end of this that even SGLT2 with a low acquisition cost are important. We can even use this drug because now the price is, I don't think, becoming a very important barrier to the use of these drugs. The side effects, we know them, we have to take care of them, and consequently we have to prevent the occurrence by proper choosing of the drug. And this, as I told you at the start, that the real wiseness of the doctor together with the patient make us choose one of the multitude of anti-diabetic agents. Thank you, Professor Ibrahim.
We're finished? Okay.
Dr. Ander is still with us? There is a question. Do you hear me? Professor Ashin.
Yes, I hear you.
Okay. Is there a relation between insulin level and the expression of ACE2?
I don't know exactly. Maybe you can ask a question to Antonio Ceriello, which is an expert in the field. I know that there is, he showed that there is a relationship between hyperglycemia and the expression of ACE2. But for insulin, I don't know exactly the answer, in fact.
Okay. Dr. Ceriello with us, Yusri? Okay. So finally, thank you for all my colleagues. Thank you very much. It was a very, I think, successful day and long day also. I hope, inshallah, for tomorrow, we will also meet again and start our next day. Thank you again and see you tomorrow, inshallah.
Okay.